Good afternoon. It's a great pleasure to be here with you, to meet you all, and also to be meeting our distinguished guests from the Romanian Orthodox Church and Bucharest University. It's my great pleasure to join you in this very fascinating consultation. We're going to be looking at a very different context. We're going to be going to the Democratic Republic of Congo. And I've been involved with a research group based at Edinburgh University, and it's part of a wider research agenda looking at the interrelationship between public health and faith communities in terms of trying to get more of a social understanding of disease. So this discussion started a few years, a little bit before COVID started, and then obviously, like everybody else, we got in on the COVID bandwagon, if you like, to quickly try and produce some research. This is we haven't got all the pictures of all our researchers, but it's very much cross-disciplinarian, so between global health, between religious studies, social development, social studies, and to a certain extent, sort of political economy understanding as well. So the team based in Edinburgh, research primarily being done by our colleagues at the Anglican University of Bunia and the Institut Pan-Africain de Santé Communautaire, also based in Bunia. So the photo on the right is a workshop that I was involved in helping to organise when we were. This was back in 2017 when we were having broader discussions about the interrelationships between faith, health, and well-being in Ituri, which is a province right up in the far northeast of the Democratic Republic of Congo. I'll show you a photo in a minute. And we were principally, in the research we went to do this time, we were principally looking at the two provinces, Ituri and North Kivu. And we're producing a series of 3 articles looking at slightly different aspects of the response and the discussion that went on during COVID. One is trying to understand the perceptions of different faith communities vis-à-vis the understanding of the disease. The other thing was the configuration of church and state relations during the COVID response. And then the final one is how were faith communities engaged or involved in public health messaging about COVID. And I think you'll find it picks up on many of the aspects brought up by Mahan, brought up by some of our other presenters earlier on today. The research teams were all based in Congo. Originally, we had hoped to go a bit further out and have a broader a wider group that we would be able to interview and bring into workshops. But for many reasons, not just COVID, as I'll mention in a minute, we had to confine it to those towns. Our work was made up of sort of 3 elements. There were sort of observational assessments by the research team looking at health security and faith community practice. Many of them themselves would belong to different faith communities. We had a series of semi-structured interviews with different leaders, both religious and health officials, and faith community members. And then it culminated in a workshop with 11 religious leaders from different church denominations to discuss and really get their understanding of what they felt had happened during the epidemic. You'll see the map there. So Congo is the huge country right in the sort of heart of Africa, really, and it borders East Africa, the East African countries of Uganda, Rwanda, Burundi, Tanzania, and then to the north you've got many conflict-affected countries like South Sudan and the Central African Republic. Over to the west, you've got the Republic of Congo, and then further south, Angola and Zambia. And it is a context, unfortunately, in the northeast of Congo of quite brutal conflict that has been raging for at least 26 years. And that's on a background of a pretty brutal colonial and pre-colonial past, and then a sort of dictatorial, autocratic kind of government model. There are currently 130 different armed groups active in northeast Congo. And even just this last week, we've heard of some very brutal killing in Ituri, where our research was taking place. I've just copied in an email from a very good friend of mine who was staying 5 kilometers away in a village to when one of these massacres took place this week, when 14 people were butchered with machetes. And he actually then visited the site because he's working with an NGO, and he says in that email, if you had seen what I had seen, it was horrible. So unfortunately, people's daily experience in Congo is being confronted with extreme acts of violence. And you can understand that when you're trying to respond to something like COVID, COVID is the 10th priority they have. They have many, many, many other challenges. And this would be something similar to what is, in terms of the Ukrainian experience at the minute, where there's a huge risk of spread of COVID with such low vaccination levels. But it's not people's top priority because they have other extreme security concerns. Another difficulty with Congo, because of the very tricky political situation and past, is that there's no real experience of transparent resource management. And many of you will know Congo to be a country that is terrifically endowed with natural resources, phenomenally rich. It's got everything. It's got water, uranium, gold, diamonds, wood. It's incredibly fertile for agriculture, but yet, so many internally displaced people, so many people in need of humanitarian assistance. That was a very recent figure, 27 million people, nearly half of the country. The economy being hit all the time because it's based on agriculture, and most people work in the informal sector. And so as these security restrictions become harder, and as you put COVID lockdown on top of that, you actually just take away people's livelihoods. So you create many, many more problems. You create real hunger and destitution. And on the whole, the trust in state institutions is really pretty low because the state doesn't fulfill some of the essential services that it should be providing, including health, but obviously security would perhaps be the very first thing that you would expect the state to be able to provide. That photo is one of my many pictures of displaced people in different parts of DRC. So faith communities and health, it's a long history. Faith communities are very important providers of health services in DRC. In terms of what are the faith communities, it's predominantly Christian. We put in percentages and we took them out actually because we don't have accurate data. It could be something like 85% Christian, about 10% a fairly stable Muslim population in terms of numbers, and then people adhering to many indigenous faith ideas as well. In Congo, membership of a religious congregation is an essential social marker, so almost everybody will be a member of some kind of religious community. And churches, in particular, run a very large percentage of hospitals and even health districts in Congo, and these are fully recognized parts of the government health system. The churches are providing them. So you've got this sort of, if you like, syncretistic institutional structure that has been there for since the early 1920s, when some of the Protestant and Catholic churches first started creating their mission hospitals. And then it widened considerably. And then when Mobutu started underfunding the state provision of health services, the church stepped up and provided a lot more. And those are some of the groups of the faith communities that we were interviewing and holding workshops with. So Roman Catholic, Anglican, some of there's many different Protestant groups, including Anglican, that we interviewed. Three people from 3 Sunni mosques, and then some of the independent churches. There's many new churches setting up all the time in places like Congo. And then there are indigenous faith groups such as Lamte Kwaro. They didn't actually make it to the workshop, but we had interviews with them. In terms of health services in DRC, so as I mentioned, there's a profound lack of investment by the government in providing health services for the people. The government, the social contract is very poorly developed. The government don't yet really provide the essentials. On paper, there's quite a good health system, and there's been quite a good district health system in place. The problem is the government doesn't manage its resources to be able to really provide that, so most is paid out of pocket. And the churches sort of step in to be providing many of these services, but they have to charge. So a sort of Catholic mission hospital, it'll be charging people, hopefully less than other places, but they still have to charge people. And that can create further poverty as well. And at the same time, we've always had a biomedical model running alongside a dimension of health seen from a more spiritual or supernatural aspect as well. And that running of health facilities really becomes part of the church's mission to serve their population. I've mentioned already, I think, the last point here about them being a really vital part of the Ministry of Health's provision of health services, or their, if you like, farming out of the provision of health services to other providers. COVID in DRC, chaotic like in every country. The state of emergency was announced in March 2020, so 2 years ago. And then places of worship were closed quite suddenly on the 10th of August, which took most adherents by surprise, and people were really quite shocked and angry about it. The public health restrictions, like everywhere, but particularly in a place with an economy so much based on the informal sector, had very adverse effects on social and economic life. But in reality, the measures were not adhered to or not really followed, so very piecemeal. The health system really has a low capacity to do test and trace and follow, so we really don't have a clue about the numbers of people who had COVID in Congo. These are recent data, but it must be a massive, massive underestimate in terms of the total number of cases. As yet, I'm not aware of a really good immunological study to tell us how many people have had the disease, but it's probably a huge number. The effects of the pandemic are unclear because of the lack of this data, but an example of that was back in June 2021. There was some sort of it wasn't quite a study, but there was anecdotal data saying that up to 5% of members of Parliament may have died from COVID. In fact, the gentleman on the right was a very, very good friend of mine, very dynamic bishop working with the Anglican Church in Goma. And he had organised a conference of faith leaders to get them to do public health messaging, completely off his own bat with other leaders. They got together, and he actually caught, we think he caught COVID. The diagnosis was never confirmed, and he very sadly died shortly after that. And I think a lot of people died without it ever being attributed to COVID. Mahan mentioned about how we can use death as an indicator, as a proxy for spread of disease. We don't really have good death data in Congo. So the kind of things that you can do is do satellite mapping. So places like Somalia, Congo, you began to see many more graves popping up in some of the public cemeteries. So there's other ways of trying to get the true effects of this pandemic when we don't really know. There had just been a 2-year Ebola epidemic. So Congo is used to really bad epidemics. And so people kind of, on the whole, made a bit more light of COVID. When you have Ebola with a death rate of 70%, COVID seemed less of a threat in people's minds. And on top of that, we have very regular epidemics of cholera, of dysentery, of measles, of meningitis. And so, as I said, COVID is number 10 on the list for many people. Health authorities were called on for their support to deliver health messages. And this is one of the things we went on to look at in our research. And we'll come to that in a minute. But as I said, our research is based on, we've producing 3 articles. The first one is looking at the perceptions of COVID in faith communities. And the background analysis to this was looking at a much broader in terms of the practices of churches, faith communities, their narratives, their judgments, and trying to grapple and understand their spirituality. And of course, there's a great plurality of view, from a real mistrust of the state to respect of the state, to distinct beliefs and practices around healing. The first response, and actually this was the majority of respondents, they did see COVID as a natural disease. They did feel that the biomedical response was appropriate, but it would need to be accompanied by a spiritual remedy, by praying with people, by supporting them, and by, in their words, by recognizing God's omnipotence in the face of disease. So the majority of faith leaders were not in any way against the sort of biomedical model, but they wanted to also combine it with their religious practices. Others, a minority, didn't see it as a natural disease. They saw it as a supernatural disease caused by God, the devil, spirits, ancestors. Different people had different perspectives. A prophetic warning. Finally, God's judgment on the Western world for its arrogance and abuse of power. So many different ideas about this, many conspiracy theories, like in every country. Or COVID is a fabricated disease created to destabilize the US? Or was it a hoax to cause fear for white people to get rich from the vaccine? So you've heard these kind of stories. Within every culture, all our societies, there's been so much fake news and misunderstanding that gets propagated, obviously by social media, but also by word of mouth. And then a certain number of people were quite uncertain about the origins of COVID and really didn't understand what it was. Knowing how trusted faith communities contribute to making meaning around health and disease, though, can help us. It really gives us insights to those of us who are public health practitioners to work out how we should better focus our interventions. So it's really important, first of all, to start by understanding what these beliefs and perceptions are. This is the kind of, if you like, the first step. The second article, we were looking at the experience and reaction of the state-imposed measures. So how did people see those measures, and how did it affect the state-faith community relationship? The closure of places of worship really did come with a sense of shock to those of faith. People felt it was disproportionate. And while they really did, in Congo on the whole, they respect the temporal power of the state, but they were really frustrated that they didn't understand why this had been done. They felt that this had not been contextualized to their context. They felt that, and other people weren't so fussed by it, because they said, well, lockdown cannot affect the Christian life because we can still have prayers in the family or personal prayers. How to maintain faith during the lockdown. It disrupted the economic model of the church. These are very poor communities. The pastors are very poor, or the imams are very poor. They rely on weekly collections, and that dried up because there wasn't any church services. So everyone was sort of having to endure these measures. They were very unwelcome in that sense. They were not involved in designing the measures. Some churches, they had a model of church that could adapt more easily, so they were able to set up this sort of cell group model to have people praying in their houses, smaller groups gathering together, so they were able to adapt a bit better. Many played a very active role in spreading public health messages and sensitizing people, both when the state asked them to do so, but also before. Many churches were way ahead, way before the state started doing good measures against COVID. Some of the church groups, particularly those that already were providing health services in health centres and hospitals, they were out there sensitizing, building awareness. Some of the larger churches, they have their own radio stations, and so they use those for transmitting messages after lockdown had started. At the same time, there's a change in relationship between health authorities and faith communities. Many of the leaders felt that they had worked well in line with the health authorities and were a model of respect vis-a-vis. They were implementing the measures. And as I said, most of them chose to collaborate. There wasn't this open hostility. They really wanted to work together because there's a bit of a history of trying to work together. They presented a model of civic-mindedness, and they themselves felt they were more conscientious than some of the state authorities. They felt that they could help the state depoliticize the messages. a point made earlier about how messages are very politicized. Actually, the faith leaders, Kathleen was talking about this, the faith leaders felt that they can help the state depoliticize the message so that it can be adopted but by believers in their communities. They were also critical that the government was saying all this but not providing any resources to speak of to actually enact the measures. And a feeling of the faith leaders desiring a better relationship with health authorities through dialogue that will allow for the experience of the faithful to be included. So that importance that Mahan was talking about dialogue between faith leaders. And this now is the summary of which we present in our third article, which is about how we can engage faith leaders in helping to better design those messages. We were asking them what was their opinion about what should happen, and this was some of their conclusions. So there was a general sense of the lockdown had happened very quickly. The state was asking churches to transmit these messages, but there was a lot of misinformation and confusion, and they weren't quite sure what message to who and how they were meant to do this. Because they lacked engagement with authorities who had not sought their expertise, they had not looked for their embedded knowledge. Some didn't want to transmit a message that they didn't themselves understand, particularly if they didn't have a biomedical understanding. They also said they lacked capacity, health knowledge, resources and time to fully transmit and implement the government measures. But as I mentioned, some were already doing this in any case. They would be much happier if they could co-create the messages. So if they could help co-create messages that would be appropriate within, whether we're talking about one co-created message or actually individual faith communities co-creating and translating something that would really strike home to their congregations using familiar language and socio-cultural understanding. They would also welcome greater training and engagement with the health authorities in this process. Many were saying that instead of shutting the churches, they should have, it would be much better if they'd instead multiplied the opportunities for awareness, because you've got this huge network of communities of faith who can actually be used very effectively to help spread messages. Some leaders were, right from the beginning, as I've said, involved in raising awareness and actually risking their lives to go and pray with the sick. Many felt that the religious texts did not in any way counteract or didn't contradict, what the messages were, because, as they said, almost all the barrier messages are in the Bible, and many would list off verse by verse exactly where in Leviticus it tells people to wash hands. Or the Muslims saying, the faithful will be convinced. Even God has already talked to us about it. And in fact, Muslims reminded us that before they worship, they have a very vigorous process of hand washing and cleansing before they go to prayers, which is in itself a public health act. And so as summary, this is looking at how potentially going forward this kind of research and some of the other research from colleagues here, what it could potentially, the questions it asks and how we can perhaps build on this. During public health emergencies, public trust in faith leaders is an asset that should be used. We should respect faith communities as being people with a huge access to many, many people in the population. In fact, the vast majority. It's an asset that's not currently used but could be. Faith leaders are aware of the effects of misinformation, and although they want to change and act on that misinformation, sometimes they don't feel they have they're not fully empowered to be able to do that. They were not happy just to be told to transmit messages. They really want to be involved in co-creating and designing these messages. because they recognise the complex social and spiritual environment in which people are working and living in. They want to use language that's appropriate, and they can really then help to counter misinformation if they are informed and involved right from the outset. They also expressed a desire to have an ongoing interfaith group that has a broader remit to discuss public health and on an ongoing basis. Clearly this needs to be contextualized in every country, in every scenario. In Congo and Ebola, they kind of had this. The difficulty is the state were paying people certain amounts of money to go to those meetings, and that of course is unsustainable the minute the financing stops. So it can't necessarily depend on finance. It needs to have something that creates a sense of ownership and desire to bring people together to really want to be on an ongoing basis discussing matters of public health. And the messages need to take into account people's beliefs and fears, recognizing how the language of faith can express the risks, values, and the importance of taking health actions. This co-production of knowledge could contribute to managing emergencies and responding to the challenges. But it requires the officials to interact with faith leaders as equal partners and not just tell them what they want imposed or implemented. So that concludes what I wanted to say. Just to say, there's a site that Edinburgh have got, this is actually trying to inspire the next generation of people into sciences and social sciences. So we're putting some of the material in sort of accessible formats for educational purposes. But I'm very happy to take questions if there are any. Thank you very much.